Can you guys see my slides?
Yes.
Okay. I will wait a couple of minutes and start it at 8:05. I think I'm gonna start here. It's already 8:05. Can everyone see my slide and can you guys hear me?
Yes.
Okay. So I think all of you guys know me. My name is Krishna Madireddy. I'm one of the PGY4 residents and UFL Adult Neurology. Today is my grand rounds, and I will be talking about providing an update on acute and chronic management of migraine. We know in the last couple of years, many drugs, new neuromodulation therapies have come up. I'll be discussing about them briefly during this grand rounds. To begin with, I don't have any disclosures for this grand rounds. So the objective of this grand rounds would be to discuss about the pathophysiology of migraine and also the new treatment options available for the treatment of acute and chronic migraine. And the outcome would be to help the participants make aware of these new therapeutic agents and also use them in the treatment of migraine patients, which we see in our clinical practice day to day. So I divided this whole presentation into demographics, where we talk about the incidence prevalence of migraine. We'll talk about the classification and common types of migraines which we see in clinical practice. We'll also talk briefly about the pathophysiology, including molecular mechanisms of migraine, on which these new therapeutic agents are based. We'll talk briefly about acute treatment of migraine and also chronic treatment of migraine. To begin with, the demographics. In a lifetime, the cumulative lifetime risk of migraine is very high. It's 3:1 in females as to males. It's 33% in females and 18% in males. Around 47 million Americans suffer from migraine. Out of this, 17% have a diagnosis of chronic migraine. The prevalence of migraine varies with age. Prepubertal, the incidence is same in both sexes, but once post-puberty, it tends to become more common in girls. Between the age of 30 to 50 years, the prevalence is 3:1, as I told, 3 to 4 times more common in women. The active prevalence of migraine throughout the world is anywhere between 8 to 15% of the population. This is an overall summary of how the pathophysiology of migraine is. There are two main systems. One is the cortical spreading depolarization and also the trigeminal system, which in turn releases all the CGRP, PCAP molecules which cause the effects of migraine. When you ask me what's the triggers of migraine, there are several triggers. One of them is genetic. As we know, in cases like hemiplegic migraine, there are some identifiable genes like CACNA1, SNCA1A, which can cause hemiplegic migraine. There are also several environmental triggers like high altitude, stress, metabolism can also cause like fasting, and fasting states can trigger a migraine in many patients. Diet, as we know, like cheese, certain type of wine can also trigger a migraine. Migraine has also been linked to menstrual cycles and also pregnancy. There are some women who have who have high prevalence of migraine during their menstrual cycles. Some type of drugs can also cause migraine. One of them is OCPs, and also overuse of opioids and other medications can also cause a migraine trigger. This is the overall, and a phase of migraine can be divided into several phases. One is the prodrome, which lasts from few hours to a day. It's the precursor of an aura. The aura itself, it consists of positive and negative symptoms like scintillating scotomas, flashing lights. Sometimes sensory changes can also be seen, like numbness, expressive language, dysfunction. These are all seen in the aura phase, which has to last between 5 to 60 minutes. Then there's the actual migraine attack when the patients complain of pain. Um, Post migraine, there's also a new phase which came out. It's called the postdramal. In this phase, patients typically complain of tiredness, increased somnolence, difficulty with concentration, and also cognitive decline. This phase, after the headache resolves, lasts anywhere between 24 to 48 hours. In a typical patient, the whole migraine episode can last anywhere between 4 to 72 hours, but there have been also patients who have a migraine episode lasting for a couple of days up to 7 days. We'll talk about each of this phase in detail. Prodrome, this is the phase before the aura. 80% of the patients complain of symptoms like yawning, polyuria, food craving, mood changes, irritability, light sensitivity, and also neck pain and stiffness. There has been several research done in this phase. They have utilized like PET scans and functional MRIs in these patients before they start having like aura symptoms or headache. The functional MRIs and PET scans have shown that there's an activation of hypothalamus, which can cause the symptoms of polyuria, yawning, changes in appetite. Locus coeruleus is also activated in this phase, which can cause sleep disturbances. Nausea, photophobia, which is one of the diagnostic criteria of migraine, uh, is also caused due to periductal gray matter activation, rostral dorsal medulla activation, and also the visual cortex. Neck stiffness and discomfort during this phase is mostly due to trigeminal cervical complex activation in the brain stem. After the prodromal phase, which lasts for a couple of days or a couple of hours, then we have the aura phase. About one-third of patients we see in our practice have migraine with aura. The aura can be of many things, but most likely it's supposed to be it can be visual, but we can also see like sensory changes like paresthesias, motor weakness, language, as I said, expressive language dysfunction, and some brainstem autonomic symptoms. The main reason for aura phase is thought to be the cortical depolarization theory. Since visual symptoms are the predominant symptoms in the aura phase, we have seen in studies in rats and hamsters that usually the visual cortex is the first region where this spreading depolarization starts. We also know from research previously that patients who have migraine with aura are at an increased risk of ischemic stroke, PF4, Parkinson's disease, and also bipolar disease. So, what exactly is spreading depolarization? It's a simultaneous, near complete depolarization of the cortical neurons. It's caused due to like massive efflux of potassium and also numerous other modulators, like there's an influx of sodium, calcium, which increases tissue metabolism and also increases cerebral hyperperfusion. What triggers it? As I previously said, there are so many environmental triggers, metabolic triggers, hormonal triggers, and also certain drugs which can trigger this. How they spontaneously start and end, we are still not sure about this. Next comes the headache phase. This is the phase when the patients start complaining of headache. This is mainly mediated by the trigeminal system pathway. As I told you, trigeminal vascular pathway and the cortical spreading depolarization are the two main mechanisms or the bench stones in the migraine. In this phase, the trigeminal and cervical efferents send their impulses to the trigeminal cervical complex, which in turn activates the trigeminal nucleus caudalis, and this in turn sends impulses to thalamus and also the sensory regions of the cortical brain through the thalamocortical projection. This is the benchmark what causes the perception of migrainal pain. As you can see, the impulses in this figure that the afferent impulses go to the trigeminal ganglion. From there, they go to the splenopalatine ganglion, which in turn sends impulses to the cerebral matter, including the dural and pia mater, and also the cerebral vessels, which can cause vasoconstriction. It also sends impulses to the cortical brain, which all cause the perception of pain in migraine. What about the molecular mechanisms of migraine? There are several molecular level peptides which are involved in migraine. One is the CGRP, which we'll be speaking about briefly in this study in this presentation, and there are also newer molecules which are identified. One is the PACAP and also glyceryl trinitrate. As you can see, once the trigeminal vascular system is activated, the CGRP receptors, the PCAP, and also the glyceryl trinitrate get activated. This is at the molecular level in the vessels. These in turn cause activation of the cyclic AMP and also cyclic GMP, which cause phosphorylation and cause activation of the sodium-potassium pump in the vessel, which in turn causes the vasodilation and also the migraine symptoms. So there's also a postdramal phase which has come up over the last couple of years. This phase is in a lot of debate as what it does. 80% of the patients who have migraine don't immediately feel well after the headache resolves. They have some symptoms of excessive tiredness, feeling weary, and also having difficulty concentration, which can last a couple of hours to a couple of days. It is thought to be due to global reduction in blood supply, which is in turn caused by brainstem nuclear activation and the trigeminal pathway. It can, since there was a reduction in blood supply and also to establish normal hemostasis, it can cause several hours to days. That's what causes these symptoms. So we know there are migraine is classified into various types. We'll talk about the common ones which we see in clinical practice day to day. The most common one is migraine without aura, migraine with aura. We'll talk about what's episodic migraine, chronic migraine, which in turn helps us classify these patients and choose the right medication. There's also certain variants like migraine with brainstem aura, hemiplegic migraine, which we see on our stroke service usually. So how do you diagnose someone with migraine without aura? They should have at least 5 attacks. Each attack should be lasting anywhere between 4 to 72 hours. It should have 2 of the 4 following characteristics. One is like unilateral location. It should be pulsatile in quality. It should also have moderate to severe pain intensity. It should also have aggravation or causing avoidance of routine physical activity or day-to-day activity, like climbing, walking upstairs, climbing stairs can be difficult. Whereas this is not seen in tension migraine, a tension headache, where people are able to continue day-to-day activities. They should also have at least one of the following: nausea or vomiting, or also photophobia and phonophobia. Talking about migraine with aura, it's something similar to migraine without aura, but they should have one or more of the following reversible aura symptoms. One can be visual, sensory, speech or language changes, motor, brainstem, and also retinal symptoms. They should also have three of the following six characters. They should have at least one aura symptom which of the following, like visual, sensory, lasting more than 5 minutes, two or more of aura symptoms occurring in succession, and each individual symptoms of aura shouldn't last any more than 60 minutes. It should last anywhere between 5 to 16 minutes. One of the following aura symptoms should be unilateral. One of them should be positive, like scintillating scleromas, flashing lights. Uh, the aura is usually accompanied by headache within 16 minutes. 60 minutes, sorry. Then we also diagnose patients usually with migraine with brainstem aura. It should have the fulfilling criteria of migraine without aura, which we just spoke about, with at least two of the following reversible brainstem symptoms. They should have at least dysarthria, vertigo, tinnitus, diplopia, ataxia, and also like decreased level of consciousness. They should not have any motor or retinal symptoms. If they have motor or retinal symptoms, they usually come under hemiplegic migraine or retinal migraine. Hemiplegic migraine, we often diagnose these patients on stroke service when they don't end up having stroke. They should be having fulfilling the criteria of migraine with aura, and also they should be having fully reversible motor weakness, which can last anywhere between 4 to 72 hours, fully reversible visual, sensory, speech, and language symptoms. Most of the hemiplegic migraine patients we see are usually like in adolescents, young teen, and kids who have some kind of genetic predisposition, as I spoke earlier, like the CACNA1A gene, SCNA1A genes, which are involved in hemiplegic migraine. So also classifying patients into chronic and episodic migraine helps us better. We know not every patient who comes in with a migraine into our clinic can be started on preventive medication. Preventive medication is usually reserved for patients with chronic migraine, like migraine episodes lasting more than 15 days a month for at least 3 months. And they should also fulfill the criteria of migraine without aura and also migraine with aura. Episodic migraine is basically anyone with migraine episodes less than those 15 days. If patient comes with migraine episodes more than 5, less than 15, that's usually episodic migraine. Episodic migraine can again be classified into high frequency episodic migraine, which is 8 to 14 days of headache a month. And it can also be low frequency episodic migraine, which is 5 to 7 days of headache a month. Coming to the acute treatment of migraine, we all know this really well. The level A evidence of acute migraine is the following: acetaminophen and NSAIDs can be used in the treatment of acute migraine. Triptans and Dietins, which is a new thing diagnosed, FDA approved in 2017. We also know about DHE or dihydroergotamine. GPANs are something new, and also neuromodulation. So triptans, this is one of the most commonly prescribed medication used for both acute migraine and episodic migraine as a PRN medication. It's first introduced in the 1990s. It acts as an agonist on the serotonin HT1P and serotonin HT1D. It acts by constricting the blood vessels. As we know, during the cortical depolarization and also trigeminal vascular system activation, there is cerebral hyperperfusion, and this acts by reversing that by causing constriction of blood vessels. There has been research done in the past, which but not clearly proven that triptans have to be used in caution in patients with stroke because it can cause cerebral hypoperfusion, and also in patients with cardiovascular risk factors, like who had an MI or things like that in the past. There are various types of triptans. We can broadly classify them into fast onset, higher potency triptans, and also slower onset, lower potency triptans. The fast onset triptans are usually the most commonly prescribed ones are the sumatriptan and the rizatriptan. They also occur in various formulations. Some of them are oral, some of them are nasal, some of them are subcutaneous. This helps because most of the patients who come in with acute migraine or have episodic migraine, they complain nausea is one of their most bothersome symptoms. In those patients, they cannot tolerate oral medications. In those patients, we can use the subcutaneous form or the nasal form. Um, there has been no proper research comparing all the various forms of triptan, but this is one study which I found which compared all the oral triptans to rizatriptan. It's a study done around in 1,200 patients. It is a randomized controlled phase 3 trial which showed comparing rizatriptan with sumatriptan, naratriptan, and zolmatriptan. All of this patients were compared the headache freedom sustained for 24 hours, and also the patient getting rid of the migraine symptoms completely. Rizatriptan has clearly shown beneficial over the other oral triptans like sumatriptan, naratriptan, and solmitriptan. These are the common NSAIDs and acetaminophen used in day-to-day practice. By the time we see patients in our migraine clinic or in our continuity clinic, most of the patients are usually on this medication. There has been evidence that usage of these medications prevents a migraine attack, but we are more concerned about the long-term usage of this medication and day-to-day consumption of this medication, as it can have renal and GI implications like gastrointestinal bleed, ulcers, and also have a renal effect. This is one of the study which showed like acetylsalicylic acid, diclofenac potassium, and ibuprofen compared with a placebo in an acute migraine episodes. All of them have shown a beneficial, like acetylsalicylic acid was like 23.8% headache freedom compared to placebo, which was 11.5. Diclofenac also showed a beneficial of 24 is to 10%. Ibuprofen, which is commonly used over-the-counter medication, has also shown beneficial of 26.2 is to 12%. The next one I want to talk about is the dihydroergotamine. It is not commonly used, but research has been shown that it is beneficial mostly for patients with acute migraine not resolving on triptans, NSAIDs. We usually use this on acute inpatient setting. It is not oral medication, it's an IV infusion. DHE is the most common form of ergotamine commonly used. It was discovered in 1945. If its efficacy lasts in the treatment of migraine is it's based on the agonist activity of 5-HT1B, 1D, 1F receptors. DHE also acts on 5-HT1A, 2A, and also dopamine receptors. Its mechanism of action is something similar to triptans. It is usually, as I told, given acute migraine, usually status migrainous patients as a last resort. There's also a new form of nasal DHE, which has not properly been studied yet, also FDA approved, available in the market. I haven't seen patients being on nasal DHE, but I have seen patients on DHE, mostly in pediatric hospitals. There are also new therapeutic agents used in the which can be used in acute migraine, which came up in the last 5 years. One is, as you all must be aware, Gpans. There are two Gpans currently available, ubrogepant and also rimigepant. Ubrogepant can be used as a 550 milligrams or 100 milligrams during an attack, and these medications have the benefit of them being repeated as needed. Rimigepant is an oral disintegrating tablet. It's available in one formulation, 75 milligrams, and is also used during acute attacks. There is also new ditans. The one is lasmiditan, which is recently approved by FDA in 2018. It occurs in three formulations, 50 milligrams, 100 milligrams, and also 200 milligrams, and can be used in acute attack. These two medications, the gepants and ditans, are usually used when patients are not effective to triptans or have contraindications to triptans, like they have cardiovascular risk factors, they had previous strokes, they also had previous coronary artery diseases, things like that. Ditans, it was came into the market as an alternative to triptans in patients with stroke and cardiovascular risk factors. It was FDA approved in 2019. It works on 5-HT1F serotonin receptors as agonists. It is has a different mechanism of actions, as we know that triptans cause vasoconstrictive effects, but as ditans lack this vasoconstrictive effects. There have been two trials done. One is the Samurai and Spartan. Both of them are again phase 3 randomized controlled trials done to prove the efficacy of lamstatin in acute migraine. These studies have shown the most common risk factor of using this diet medication is there is a driving impairment. They should not be driving for 8 hours after the administration of lamstatin. So both these studies, the Samurai and the Spartan, are phase 3, as I mentioned. They studied two main endpoints. One, the primary endpoint is pain-free after 2 hours after administration, and also the secondary endpoint being the most bothersome symptoms, let it be photosensitivity, nausea, vomiting, whatever the patient has seen. And it has been shown to be beneficial both in almost all the three forms, the 50, 100, and 200 forms, in both in patients who are already on preventive medication and also those who aren't on preventive medication. They studied around 500 patients using already on preventive medications and also like 3,000 patients who are not taking any preventive medications, and it showed statistically significant results in both this subset of patients. Next, we'll talk about gepants. There are two gepants currently available. One is the ubrogepant. Uh, uh, there has been a phase 3 study done on this medication too. It showed, compared to a placebo, both the 50 milligrams and 100 milligram tablets have shown uh, pain-free within 2 hours, around in 19 to 22% of patients compared to placebo. And also the most bothersome symptoms, again, this can be anything between nausea, photophobia, photosensitivity, and it showed like 37 to 38% relief of the most bothersome symptoms as compared to placebo. The most common side effect noticed in patients with this gepant was nausea and dizziness, which was seen in roughly 2% of the population. Rimigepant is another gepant. It is an oral disintegrating tablet. As we said, it occurs in only one dosage, and we have seen that they have studied the pain-free interval in 2 hours, and it was 20 to 21% compared to placebo, whereas the most bothersome symptom relief was 35% compared to placebo. Again, compared to other gepants, it had similar side effects, which was nausea and dizziness. So what kind of gepant can you use in patients? So it depends. Ubrogepant is used both in acute is used approved for acute treatment, whereas rimigepant is used for acute treatment and also episodic migraine prevention. As I told you, ubrogepant is an oral medication. It can be used again if the headache doesn't get relieved, whereas rimigepant is a one-time oral disintegrating tablet. There has been also new neuromodulation devices which came up in the last couple of years in the treatment of acute migraine. These are all been FDA cleared for acute migraine. One of them is transcranial magnetic stimulation device. There have been also supraorbital transcutaneous nerve stimulation. There have been also non-invasive vagal stimulation devices and also remote electrical neuromodulation devices. These should be considered in patients who have contraindications to standard migraine, in which who have side effects to triptans, dietans, or gepants, and also who have been overusing the triptans and gepants with minimal pain relief, and also who can be used in patients who prefer non-drug therapy in the treatment of their acute migraine. We'll talk about most of the devices as we come on. So this is one of the meta-analysis of randomized controlled trials done using these neuromodulation devices. As I told you, there are several kinds of neuromodulation devices. One is transcranial magnetic stimulation devices, non-invasive vagus nerve stimulation devices. Even in these studies, the primary outcome was to see if there's pain freedom within 2 hours of treatment using these neuromodulation devices. Secondary outcomes was a sustained pain relief more than 48 hours of using this neuromodulation devices. They have found benefits between 2 hours, but no significant effect in pain relief after 48 hours using these devices. So as a result, these neuromodulation devices can be used in acute migraine prevention, and they have been FDA approved for the same. The first device is the Cephali device. It's an FDA approved for acute preventive episodic migraine. It's an external trigeminal nerve stimulation device. It activates the trigeminal nerve complex through the forehead. As you can see, this device is basically you keep it on your forehead during your acute headache episodes, and it stimulates the trigeminal nerve, and it gets headache relief within 2 hours. The other device is the Gamma Core. It's a non-invasive vagus nerve stimulator. It's been FDA approved for acute and preventive migraine treatment in patients ages 12 or more. It activates the vagus nerve. As you can see in the second image, the patient needs to stimulate the vagus nerve during an acute migraine episode. The other device is the Relvion, which is an FDA approved for both acute treatment of migraine with and without aura in patients 18 years or older. This acts by both activating the occipital nerve at the back and also the trigeminal nerve as a cephalic device in the front. Um, the other one is the STMS Mini. It has been approved for acute and preventive migraine in ages 12 or more. It's a transcranial magnetic stimulation. It acts by, it tends to have an effect on the cortical depolarization. It's put behind the head, as you can see in the second image, during an acute migraine episode. The third final device is the Nerivio. It's been approved, FDA approved for the treatment of migraine in patients ages 12 or more. It has a remote electrical neuromodulation or REN. It acts by stimulating the nerves in the forearm during an acute attack, and also it acts by inhibiting neurotransmitter release. So we spoke about various treatment options for acute migraine. As you can know, this is overall to simplify the acute treatment migraine management. Uh, we can start in any patients who have less than 3 headaches with an NSAIDs. And if they're having more than 3 episodes, we can start a treatment of triptan along with NSAIDs like naproxen. And if they're having more than 3 attacks of migraine non-responsive to treatment, then we can go for one of these two dietins or gepants which are now available. Talking about chronic preventive management of migraine, as we all know, there are several medications which we can use. There are some medications which have established efficacy. Some of them we have which can be probably effective. The most common established efficacy medications are metoprolol, propranolol, Topamax, sodium valproate, and also the new monoclonal antibodies, along with botulinum toxins, which have all proven to be have established efficacy in as preventive medications. As I showed this figure before, the molecular basis of acute migraine comes with the trigeminal vascular system activation to the CGRP receptors. Currently, there are four monoclonal antibodies FDA approved in the treatment of migraine. One of first them is erinubab or Aimovig. I included brand names because most of you guys are more familiar with brand names. Galcanezumab is the second one. Fremonizumab is the third one, and also the new one which recently came up, which is an IV form of CGRP monoclonal antibody or eptinezumab. The main differences between these four monoclonal antibodies are the newest one is the eptinezumab. It is an IV form. Patients need to be admitted or need to have an infusion of this. It's a 100 to 300 milligram IV infusion, which happens to be every 3 months. The time of onset is anywhere between 2 to 5 hours for this medication, and it has a half-life of 27 days. The first one FDA approved is the erinubab. It comes in two forms, 70 or 140 subcutaneous or monthly infusions. The time of onset of this erinubab is 5.5 days and has a half-life of 21 to 23 days. Tremelimumab is a 225 milligram subcutaneous monthly infusion, the most common form, or it can also be 675 subcutaneous, which can be done every 3 months. It has a time of action of 5 to 7 days on an average. The last one is the galcanezumab, which is available in two forms, 240 subcutaneous loading dose and also a 120 milligrams subcutaneous monthly dosage. It has a time to maximum of 7 to 13 days and a half-life of 28 days. We'll be talking about each one of them a little bit briefly. All these monoclonal CGRP antibodies have been studied in both episodic and chronic migraine, for which they have been FDA approved. Erinubab was studied in randomized controlled phase 3 trials, which consist of, in episodic migraine, they studied around 250 patients. They have seen a mean reduction in the number of migraine days, which was 6.6 compared to 4.2 in placebo. Both the 70 milligrams and 140 milligrams erinubab seems to have similar efficacy, but they were clearly efficacious compared to a placebo drug. In these trials, the most common side adverse event they have seen was injection site reactions, upper respiratory tract infections, and also nausea. The second medication which we have here is the fremonizumab or Emgality. This has also been studied in chronic and episodic migraine. The first slide is about the episodic migraine, which was a randomized controlled trial. They seen fremonizumab as a monthly dosing and also as a single dose higher medication, and they found it to be the single dose and monthly infusion subcutaneous dosing was clearly efficacious to 8.9 to 4.9 versus a placebo versus 9.2 to 5.3 in patients considered versus a placebo. This was a fremonizumab in episodic chronic migraine. This was also a phase 3 randomized controlled trial studying around 1,200 patients. In this, the medication was divided into quarterly and monthly, and they compared it versus a placebo. It reduced the number of migraine days by 4.3 in quarterly dosing and 4.6 versus in monthly infusions compared to a placebo. Again, the most common adverse event in this clinical trials was injection site reactions, um, and also diarrhea. The third medication is galcanezumab, which was there was a phase 3 randomized controlled trial done, which was called the REGAIN study, in which they studied around 1,900 patients, and they found that the 120 milligrams and the 240 milligram galcanezumab has an mean reduction of headache days of 4.8 compared to 2.7 days in a placebo. And again, the main adverse events in these studies was also injection site reactions, anaphylaxis, and erythema. Galcanezumab was also studied in the trial of episodic migraine. The name of the trial was EVOLVE. In this, they studied galcanezumab again as 120, 240 versus a placebo, and it showed a 4.7 reduction in 120, 240 compared to a 2.8 reduction of headache days in placebo. Eptinezumab was the newest IV form of monoclonal antibodies. It was studied in PROMISE-1 trial, and it did show a reduction of headache. There were three formulations which were studied: 30, 100, and 300. All of these formulations were clearly effective compared to the placebo, as you can see here in graphs. And they had a headache reduction anywhere between 4 days to 3.9 compared to a placebo, which is 3 days. So, what do you tell patients when you prescribe this monoclonal antibodies? All of these four medications have somewhat similar efficacy when studied in trials. Even if others have trial, the other medication can be used. They can also be used in medication overuse. Uh, Even with significant comorbidities, as you can see, the adverse events in all of these clinical trials have been minor injection site reactions, erythema, diarrhea, nothing life-threatening. The onset of action of these monoclonal antibodies can be anywhere between the first day and first week, and their studies have shown that the efficacy of monoclonal antibodies increases over time. If if a patient fails one monoclonal antibody, that doesn't mean he's going to fail the rest. There have been studies shown which showed that other monoclonal antibodies can be used uh, if one monoclonal antibody fails. The most common side effects are, as I said, adverse site reactions. Constipation has been found to be most common in Erinumab. Recently, FDA gave a new warning of Erinumab that even hypertensive majority within the first week is common. There will be patients in whom even and the monoclonal antibodies might not be effective. Um, Women who are trying to conceive should wait at least 5 months from the last dose of the monoclonal antibody. This is an overall summarization of all the trials done for episodic migraine using this monoclonal antibodies. As I can say, eptinezumab in the PROMISE-1 trial, ennumab in the STRIVE-1 and ARISE clearly shown beneficiary effect compared 50% is to 26% in placebo in the STRIVE study, and also 40% is to 30% in the ARISE trial. Even galcanezumab has been clearly effective compared to a placebo in episodic migraine, 62% versus 38% in placebo, and also 59% versus 36 in chronic migraine. So these are the medications I wanted to bring up in the study. There's also few more studies being done in the treatment of migraine trials. The new medications are PGI2, and also PCAP. Studies have previously shown that infusion of this PCAP can cause headache in patients, and also there are currently phase 2 trials and being underwent to study the efficacy of these new medications, but they're still not FDA approved. We can expect these in the next couple of years. That is my last slide. If you have any questions, I'm willing to take that.
Hey, Krishna, that was a nice review of those uh, new treatments, the treatments that I really don't use all that much or haven't used yet. Could you go back to really any one of those slides that has the start to separate from placebo? Okay, like this one. So in this study, the difference was 6.6 fewer days with migraines, and
Yes.
placebo always works placebo is the most consistently effective treatment for migraines, 25 to 35%. And it's the most studied treatment for migraines, and it consistently works every time. But the number here is change. I mean, they cut it. They even put 4 and 4.5 and 5. And what was the starting? Do you remember, or did you happen to read, like, how many did they have at their baseline? If the difference was reduction of 6 days versus 4 days, or 7 days versus 4 days, if you have 30 migraines a month, that's not a huge change. If you have 6 migraines a month, that's a big change. What do you remember in this study? What was the baseline?
So they mentioned they took in population with chronic migraines, like more than 15 headache episodes at a month. They clearly didn't mention they can be anywhere between 50 to 30, or even sometimes everyday headache patients. So they didn't clearly mention what's the average number of headache days these patients are having.
Okay. And the next slide is kind of the same way. It's a drop in frequency of 4 versus 3 versus 2.5. And these are the same thing in someone who has migraines 30 days out of the month. Potentially someone who has 30 days out of the month. Placebo, they only had 28, and with the treatment, they only had 27 or 26.
Yeah.
It's always important to look at the y-axis. If it's a percent of days, like the one on the right, y-axis doesn't go all the way to 100, then maybe they're trying to stretch it out and make this difference look bigger than it really is. But I'm sure we'll be using these in resident clinic. Thank you for the review. I should know how these things work if we're going to be signing off on them and refilling them. Thanks for the talk.
Sure, thank you.